Good evening to everybody from Mesa, Arizona, in the western part of the United States. I know it's evening where you are in Europe right now. And what we're going to talk about is probably one of the most exciting additions to anterior segment surgery to come along in quite a while. And it's the Eyestar 900, and it's basically a reimagination of biometry. It's a whole new way of thinking about what a biometer should be. This little device here combines all the instrumentation that an anterior segment surgeon needs, and it really replaces a whole room full of equipment. And as you'd expect from Haag-Streit, there really aren't any compromises. It does anterior segment imaging, it does topography, it does keratometry, and also all the axial measurements in a way that's consistent with what we all know Haag-Streit to be. So nothing is compromised, everything is high definition, and the measurements are very highly sophisticated. One of the things that's most exciting about this instrument, and something I've been preaching for years, is that a measurement's only as good as our ability to know what it means. And the device actually has built-in validation criteria. So when you see a little check mark, which I'm going to demonstrate in a few slides, next to a measurement, it tells you that the measurement's been internally validated by the machine. So we don't need to keep those little index cards next to the device anymore. It does it for us. If you have a busy clinic like we do, what's interesting is it does both eyes automatically in 40 seconds. Think about how much that's going to increase the efficiency of your clinic. And all of the measurements are completely automated. So that means that the technician with the least experience and your most experienced staff members get the same level of accuracy. So that's remarkable as well. So a lot of things are sort of taken out of our hands, and the machine actually probably even does a better job. So a quick overview. It uses swept source OCT of the entire eye, but it does it in a way you've not seen before. And I'm going to share with you how that works. The A-scan representation is a very familiar scenario. It looks like an immersion A-scan, and I'll show some images of that. And then we have multiple high-resolution, high-density B-scans, especially of the front part of the eye out to about 18 millimeters. So this is really everything that we need and we use in anterior segment surgery. The topography is a typical type 8 topographer, kind of like the Atlas topographer. And it does direct measurements of both the anterior and the posterior cornea. So unlike some biometers that have to iterate the power of the posterior cornea, this is a direct measurement. And it also gives us spirometry, which is very, very important for, say, certain ectatic diseases like pellucid marginal degeneration and keratoconus. My area of interest is, of course, on the Zernike tree, and I'll show you some ways that we can have a conversation with the patient to either help identify why they're having difficulties with their vision, or also to screen for multifocal IOL candidacy. It does real-world image simulation in a way that's almost exactly what the patient sees. And sometimes when we show the patient the image simulation, they say, "Yes, doctor, that's what I've been trying to tell people for a long time. Yours is the only office that actually understood what I was trying to say." And it has zone-based keratometry. This is really helpful for both the toric IOL and making decisions about multifocal IOLs. So let's begin with Mandala scanning. Um, Mandala scanning is a way in which the OCT laser samples the eye, both in the front and the back part of the eye. And if you're used to how anterior segment swept source OCT um, measures the eye, we're used to these low density radial scans. And this does a Mandela scan, and you can see instantly how the density of the measurement is completely different. Much more data is generated. And the nice thing about this is that when you have all these data points, they can be stitched together to allow for things like motion compensation, increase the density of the scanning for a higher resolution, and also provide anterior segment imaging, which we'll go into at the end of the presentation. So we scan an area, we create segmented images, and we can stitch them together for motion compensation with biometry, for keratometry, for sophisticated topography and also imaging of the anterior segment by B scanning. So this is an idea of how motion compensation works. If you have limited information, you have limited resolution, and with lots and lots of information, you can increase the resolution. So this would be just a simple OCT B scan of the anterior segment. But this is kind of how it works. We have lots of different information. We put it all together, and then we can compensate for motion. As the patient sits at the instrument, the eye undergoes little tiny saccades. And this can be a problem for like Scheimpflug photography, where it takes the camera about 2 seconds to rotate 360 degrees. And those little saccades can sometimes influence the accuracy. This overcomes that. So this is kind of how it works. Here's one Mandala scan, a second one, a third one, et cetera, et cetera. And the device can stitch all these together and give us a very high resolution image, which is very nice. Now, we also use the swept source OCT for the axial measurements, and that would be the central corneal thickness, the anterior chamber depth, the position of the anterior capsule, posterior capsule, all the components of the lens, and then down to the RPE. And it's presented in a way that looks exactly like a familiar immersion A scan. And while it's doing this, it's also looking at validation criteria. So here's an eye with an axial length of 18 millimeters and anterior chamber depth of 1.8 millimeters. This is obviously we get a heads up that this is a very unusual eye. Because the measurements have such high accuracy, and you have a B scan right in front of you, there's no question as to the veracity of the measurements. And it even gives us some little caution symbols that these are way outside what we would normally do. You only need about 1.5 or 1.6 millimeters. So if to do an accurate set of axial measurements, and here's somebody with a Kimura corneal inlay, and you can see we only have 1.6 millimeters to work through, and you can see it's a completely normal swept source OCT measurement of all the axial measurements, and every scan is valid. So if you have a patient, say, with a pilocarpine pupillary membrane, they just can't dilate, we can still get through that, and it looks very nicely. Now, one of the questions that comes up very frequently with any new biometer is what is the dense cataract penetration? And everybody talks about this. Well, I'm going to show you one of our own patients where 38-year-old lady had a prior retinal detachment. She has some early diabetic eye disease and had a dense post-vitrectomy posterior subcapsular cataract. And you can see her vision before the measurement is hand movements. So this is with the IOL Master. We basically just have no return signal from the retina whatsoever. This is the LASIK, which usually does a very nice job, but really nothing meaningful. And even in the dense cataract mode, we have no signal that's usable, and the machine gives us a warning sign. And it's a very dense PSC plaque. So let's go to the Eyestar. The right eye is completely normal. The left eye, you can see the dense PSC plaque. And even though the retina signal is reduced, which is understandable because it's very dense, it still meets Eyestar validation criteria, and we can use these numbers. So this is the measurement summary page. You can see that the axial length is measured at about 22.07 millimeters. But you see the little check marks next to the keratometry and the topography. What it says is internally, the machine has looked at multiple measurements, and they have met validation criteria. So this is the same as having that little card next to the, say, the LASIK, and making sure that all the measurements are correct. Well, the machine does it for you. So it's like having, your own assistant inside the machine, making sure everything's correct. So not being willing to accept that in the beginning, I myself did an immersion A scan on this patient, and you can see that the average axial length is 22.07 millimeters. So the machine got it right, even through a very dense posterior subcapsular cataract. Now, one of the really best things about this instrument is the keratometry and topography features. And for those of us who develop lens power calculation methods, the keratometry is really the noisiest part of the entire exercise, um, where a one diopter error in keratometry is a one diopter error at the spectacle plane. And then we'd like to have keratometry not only for, I mean, topography, not only for diagnostic purposes, but also to help us determine the orientation of the steep and the flat meridians. So there's no compromises with this. And one thing you might notice about this right away is that the two rings of LED lights that are used to measure the cornea, they're not in the same meridian, they're canted. So they're separated by about 11 degrees. And what this does is it increases the density of our measurements. So it's the same dual zone keratometry that made the LenStar so famous. It has telecentric optics, which means if the patient's a little bit forward or a little bit back, it doesn't really impact on the accuracy. And because the Ks are set up in such a way to reproduce those Ks of the LenStar, but have a much more robust measurement, you don't need to update or modify your lens constants like you do with some biometers that you get. So this is kind of what it looks like. We have 32 measurement points. It's two rings, 1.65 and 2.3 millimeters. But instead of being in the same meridian, they're interdigitated. And the keratometry is centered on the visual axis. And again, these Ks are robust and very reproducible. And I'll show you an example in a minute of how robust these are. And only one measurement's required to collect all the keratometry data required for validation criteria. So let's do a little comparison. Here's the IOLMaster 500 and earlier. What we have is we have 6 measurement points, 3 above and 3 below the horizontal meridian, and they're separated by 60 degrees. And those of you who use the earlier IOLMasters remember that where are these numbers, the least accurate? Well, it's at 90 degrees, isn't it? And that's because that area is between measurement point number 1 and number 6. Valmaster 700 did a better job, didn't it? And we have 3 rings, 18 measurement points. They're separated by 30 degrees. So that improved the measurement density. So they did a good job on that. Let's look at the LenStar. This is our old and trusted friend, the LenStar. And these types of Ks really redefined what was possible for measurement accuracy and also for the Toric IOL. And those of you who used the LenStar in the beginning remember how much your Toric IOL outcomes improved with this. So here they're separated by 22.5 degrees, and we have a high measurement density with 32 measurement points. Now, here's the Eyestar 900. Again, we have 32 measurement points, but they're interdigitated, and you can see that we now have increased density. We're at 11.25 degrees between the measurement points, not 22.5. So what we've done is we've increased the measurement density, so there's less iteration that has to take place, and more information, just like with the Mandala scan, more information, higher resolution, better outcomes. Now, here's a patient who had radial keratometry, and out where I live in the southwestern United States, in what we call the keratorefractive Wild West, there's lots and lots of refractive surgery being done, and a lot of radial keratotomy was done in Arizona, California, and in Florida. So we see a lot of RK patients. And unfortunately, these patients can have very distorted corneas. And the old entire joke that we have is radial keratotomy is the gift that keeps on giving, which means that these people continue to flatten their central cornea over their lifetime and also to develop various forms of distortion. So here's an original IOLMaster. You can see that we had no keratometry possible at all. Here's the LenStar, and a little bit of a surprise here, absolutely nothing with the LenStar. So let's look at the Eyestar, okay? So with the Eyestar, for this patient, we can actually generate a topographic axial curvature map. We have usable keratometry. We have validated numbers, and we even get diagnostic feedback, and it tells us the Gould-Strand ratio is elevated, which is what we see with RK, and that we have an unstable ocular tear film. That's really no surprise for the RK patient. So 2 instruments where we couldn't get anything here. The measurements are very robust, and it gives us completely useful information. So this is a real-time video keratograph of the keratometry, and this is just part of the machine that you get a chance to look at this and make sure there aren't any smeared areas or any of the LED measurement points missing. And if so, then of course you need to optimize the ocular surface and then redo the measurements. And this is, say, for toric IOL planning, we have all the information we need. We can see if the measurement is, if the topography rather is symmetrical and regular, and is this a toric candidate? So, is the astigmatism regular? Well, can we pass a line through the corneal vertex and the two centers of the astigmatic lobes? Okay, that's regular. Is the astigmatism symmetrical, which means we have similar power on either side of the corneal vertex? And of course, a toric IOL is nothing but a cross cylinder, so it's a completely regular optical device. What's the orientation of the steep meridian? That would be that line again that passes through the corneal vertex and the center of the two astigmatic lobes. And then what's the power difference between meridians? That's the astigmatism of the cornea that we're looking to correct. And then are these numbers consistent and validated? We get those little check marks next to where it says topography and keratometry. And that tells us that the instrument has gone in and validated the numbers for us. When it comes time to do the calculation, we've got pretty much all the tools you need. We have the Barrett toric calculator that uses the measured posterior cornea that's built in. And if you like, there's the Abulafia-Koch Hill RBF method, which does the toric spherical calculation using artificial intelligence and has a very, very accurate regression algorithm for the posterior cornea. Pretty much every calculation method you need for normalized refractive eyes and toric IOLs is built into the instrument for us. If you don't have an orientation device on your microscope or an operating system that allows you to do this through the microscope, the Eyestar will generate a white light image for you that gives you a wealth of information. And what some people will do is they'll take this image, they'll print it out, they'll turn it upside down if you sit at the patient's head, and then put that on the head of the microscope. So you get a lot of information, the representation of the IOL, the steep meridian, the flat meridian, the reference meridian, which is, of course, where we put the marks in the holding area if you mark the cornea manually, the location of the incision, and then the calculated meridian of toric alignment. So the machine provides this for you if you wanted to use this in the operating room. So the topography feature of this instrument, again, is no compromises. And we generate a lot of information from the topographic map, and we're going to go over a little bit of how that works. The machine generates the 4 basic topographic maps. There are many more topographic maps than this, but most people don't use them. So these are the 4 standard topographic maps that a lot of people use in their practice, especially if they have optometrists that fit contact lens. And those, by the way, those 4 maps, let's just go back to them for a minute. Those 4 maps are from the same eye of the same patient. So this is what we're all familiar with. This is the axial curvature map, and it goes out to 12 millimeters. If you think about your current topographer, chances are it goes to 8 or 9 millimeters. This goes all the way to the limbus, which is very helpful for diagnosing certain diseases, especially the ectatic ones. One limitation of an axial curvature map is that it assumes that all the rays of light go through the center of the cornea. And for things like the toric eye, well, that's fine because the center of the cornea is what we're mostly looking at. And it's often used to characterize the type and alignment of the astigmatism, what we talked about just a minute ago. So is the astigmatism regular? Is it symmetric? Is the patient a toric candidate? And and what's the location of the steep meridian? Do they have with the rule, against the rule, oblique astigmatism, et cetera? So pretty much everything you need for doing the toric IOL is right there. And just quickly, we'll go over some things that optometrists use. This is a best fit sphere map that's sometimes used for contact lens fitting. The machine comes up with the best fit sphere, and it displays those things that may be above or below the best fit sphere. And again, this is used a lot by optometry. There's also a best fit toric map, same exercise, except it's looking to see for a best fit above a toric reference model. And for those of you that may work with keratoconus or highly irregular corneas, it has a tangential curvature map. And the tangential curvature map is a little bit more sensitive to local irregularities and showing transitions in curvature than the axial map. And it'll end up looking a little bit smaller, has less data smoothing. It's not used as much by us because we're more familiar with the axial map. And it's really useful for keratoconus, pellucid marginal degeneration, prior refractive surgery, penetrating keratoplasty, prior injuries, things like that. Now, it has an image simulation feature, and this is very helpful. We have a big LED display on the wall of our diagnostic room, and we will do image simulation for our patients and show them that we understand what it is they're seeing. And especially for patients that have had prior refractive surgery, this is incredibly useful because all aberrations, as we know, are radius dependent, which means the larger the pupil, the more influence of the aberration. And we can show people why perhaps they may not be a multifocal candidate if they've had prior refractive surgery or they have a highly irregular cornea. And this is just an example from one of my own patients. Here's somebody that's had an 8-diopter myopic ablation. You can see that the ablation is actually a little bit decentered. And that has some implications as far as how they see with a larger pupil. So we have central flattening and we have decentration. So automatically we know that we're going to have elevated spherical aberration and we're going to have coma. So this is the aberrated part of the cornea and the intermediate marginal areas. So here's their spherical aberration. And as we know, the normal value for spherical aberration is 0.274. This is 1 micron, so that's a lot of spherical aberration. And you can see how the image is distorted compared to what the big E should normally look like. Here's our horizontal coma, and coma produces image displacement and duplication. And then here's our vertical coma. So this is what this particular patient is struggling with at night when they have a larger pupil. At the smaller pupil, they see a little bit better. So if they come in and say, doctor, I really can't drive at night. I'm having all kinds of problems. Well, we can show ourselves and also the patient exactly what the issue is. And unfortunately, there isn't an IOL solution for something like this, but there are solutions, and I'll demonstrate that to you. So here's somebody with a toric IOL. And they have some basically it looks like with the rule of astigmatism. We can show them what their vision would be like if we had just a spherical IOL, and again, without glasses correction, their mesopic vision and their scotopic vision. And this allows them to see very nicely that with the toric IOL unaided, they would see better. Here's somebody with myopic LASIK, and really not a surprise. They see better during the day than they do at night. And we can show them that with a scleral contact lens, we could return their vision to something that's almost normal. And here's somebody with hyperopic LASIK, same thing. With a smaller pupil, they see a little bit better. This is a very irregular cornea. Toric IOL probably wouldn't be indicated here. But with a scleral contact lens, we can get things almost back to normal. And then here's the bane of our existence out in the southwestern United States, radial keratotomy. And you can see with a scleral contact lens, it makes a huge difference. There wouldn't be an IOL solution for a patient like this. And we're also, you notice in the upper right-hand area, we have diagnostic information telling us that the Gould-Strand ratio is elevated. We're just going to briefly touch on a few features of the AC suite. Mostly we're talking about keratometry and topography. But I just wanted to just remind you that we can do topography now up to 12 millimeters. And, those of you who are cornea experts, often you get patients that come in with, the pattern of the kissing dove or the lobster claw and say, well, I was told I had pellucid marginal degeneration. Well, we can image way out into the periphery, and you can look for that little clear area down below. And if you really don't see it, what they probably have is just a variation on keratoconus. Pellucid marginal degeneration is a pretty rare diagnosis. So most of these people have keratoconus, and here we can show it. And again, we're not going to spend a lot of time on this, but we can do difference in trend maps, and you can set them up any way you want so you can track things over time. And this is especially important for things like keratoconus, where we're looking for progression over time. And it can be set up really in a whole different number of ways. So if you see a lot of keratoconus patients, this can be very, very helpful. And you can track things and graph them over time. And then the Ectasia display is very helpful, especially with keratoconus patients. We have Michael Balin's ABCD grading system and Biometry and the Keratometry indices. And so this should be very familiar for any of you who work with keratoconus patients. And we have a lot of the features that we're all familiar with. One last thing we're going to talk about is the anterior segment imaging. And again, we can go out to 18 millimeters with a swept source OCT. And one of the things I like to do is I like to measure the angles. And it's surprising if you actually measure the angles, what you see. And one of the rules of thumb is if the angle's less than 15 degrees and greater than 10, that's obviously an eye that we need to start thinking about. And if it's less than 10, we need to start thinking about doing something. We're offering our patients a lens extraction because that's definitive, but some people would do an iridotomy. And what's interesting about this eye is we have asymmetric narrowing. So nasally and temporally, the angles are completely different. And you can follow this, but because it's 14 degrees, I think we might think about doing something for this patient, probably a lens extraction. And just a couple quick examples of it. Here's a patient with a penetrating keratoplasty. Here's somebody with intact intrastromal corneal rings, probably for keratoconus. But the anterior segment imaging is really quite nice, and it allows us to see a lot of things very nicely. Here's a patient with pseudophakic bullous keratopathy with increased corneal thickness before DMEC, and then this is one after DMEC, and you can see the dramatic improvement in the corneal stromal thickness. So basically, in summary, this is a whole different way to think about biometry, isn't it? It's a complete reimagination of how to do biometry. And as anterior segment surgeons, this is pretty much the must-have instrumentation. The fun thing about this is it replaces almost an entire room full of equipment. So if you're thinking about setting up a separate office, or maybe you're new in practice, you can use this instead of a lot of other very expensive devices. None of the measurements are compromised. So it does a lot of different things, but it doesn't do them with being compromised. And everything is high definition. The measurements are automated and completed in 40 seconds. That's really quite remarkable. And then one of the very exciting original things that the machine does is it does validation criteria for you, and it's automatically applied to the instrument. So what we get with this, the whole point of this is happy patients. And as we do better measurements and get better and better at our calculations and the plans we have for our patients, we can keep our promises to them, and we can make them happy. And this is the best payoff of all, is that we get patients who are really pleased that they came to see us and that we can keep our promises to them. And I think that's what matters most of all.